The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Greetings and welcome to our LymphCast show, episode 27 tonight. Let's go around the room and meet our panel. From Arizona, Dr. Monica Gloviczki. Greetings, Dr. Gloviczki. How are you today?
Hi, hello everybody. Happy to be with you for this next episode of LymphCast, and especially happy because just today we have a Polish guest. And as some of you know, I am with Polish origin, so of course it's close to my heart to have somebody from my country.
All right, very good. From New Jersey, medical professional Jacqueline Sasek. Hello, Jacqueline. How are you today?
Paul, how are you? Happy to be here today.
Good. Tell our viewers and listeners again what you do in the medical profession.
I'm a registered vascular technologist, and I'm a former director of Dr. Chuback's Vascular Lab.
All right, very good. Speaking of Dr. Chuback, from New Jersey as well, the director of this show, the producer, the founder of the LymphCast show, also the founder and owner of VitaSupport MD, makers of Lymphatic Formula 1000 and Vein Formula 1000, the physician surgeon, Dr. John A. Chuback. Hello, Dr. Chuback. How are you today?
Hi, Paul. Doing fine. Thanks so much.
Very good. Quick correction, Jacqueline. I think I moved your house a few minutes ago to New Jersey. You actually live in New York, right?
Yes, correct.
Sorry about that. You didn't move. That's on me.
She's a Jersey girl at heart. So
That's
don't
right.
worry.
That's right. From California, Dr. Emily Iker. Hello, Dr. Iker. How are you?
Hello, everybody. What a great honor to have Dr. Marzanna from Warsaw to join us at this LymphCast discussion today.
All right. If you'd like to give more information on her and introduce her and then ask the first questions, we'll be good to go.
Well, it is my great honor to welcome Dr. Marzanna Zaleska. She is so well known throughout Europe, as well as now she's going to be known in the United States as well. She's very accomplished, and I just have to tell you, Pearl, we know each other for quite a few years, many years. And way back when I had a discussion with Dr. Olszewski and asked him to have a disciple, someone who would follow his incredible work. And he said, I already found, and I found Marzanna. So it was a great honor that he selected you, my darling, to carry on his work. And as we know now, you are involved with so much research, 61 research work, 555 citations, 4,197 reads, and the list goes on. And I am so honored to welcome you today to our show. And I will have first question. Tell us, how did you start? How did you figured out that the lymphatic system is something that you are interested in and that you want to work with?
First of all, thank you for inviting me and the possibility to share my work. I start my work with in lymphatics because of Professor Olszewski, of course. She was my boss, and she was interested me in this study. I worked with him many years, and he was so passionate in lymphedema, and I started also. It
And-
was many years ago, more than 20 years ago.
And Marzanna, could you just tell us, because it's a huge achievement. You are now not only the accomplished researcher, but you are really part of the highest scientific organizations in Poland. So tell me, are you having a medical diploma, or and that's how you started, or this is a diploma in sciences?
I'm therapist.
Therapist.
I'm physiotherapist.
Okay. Mm-hmm.
Yeah. So, but first of all, I'm a researcher, I think, but
Yeah,
also physiotherapist. So I have contact with patients.
Wonderful. That's something that I was missing a little bit, because I
Yeah.
know you research, but I wasn't sure if you are also having the direct contact with patients.
Yeah. Yes. Every day.
Wonderful. And could you tell us a little bit, what is your current research topic? What is the hottest now, what you are doing currently?
Oh, there is a lot of topics. I prepare even some slides to show you some part of my work. So I can say that one of the hot topics is very early detection of edema with using of ICG. This is extremely important now, because the patients is more and more, patients with lymphedema is more and more. And we all know that the treating edema is more successful when we start very early. So the early detection means better outcome. So this is one topic. Another one is for many years, compression. All types of compression and the effect not only on the volume reduction, but also, which is more interesting for me, the effect of compression on changes in skin and subcutaneous tissue, as fibrosis and this type of changes. Because for sure it should be the effectiveness on this, and I try to document it. Another topics is also a different type of compression adjusted to special patients and special situation. I prepare some slides about this one method of this special type of compression, which we together with Professor Olszewski started to use, and I continue it. This method. I also interested in differentiation between lymphedema and lipedema, which is not always so easy for everybody. So
what method do you use to differentiate lymphedema from lipedema?
Sorry, how?
What method do you use?
I try to find the method which would be the easiest and more convenient to differentiate. One of this method is, of course, even simply ultrasounds.
That's what I do, right?
Yeah, what you do, I know. Yeah, I know your study. Yeah, and now we're starting also working with ICG with elastography. So I think this method also help us to show the differences and show help differentiate this two type of diseases.
Right. Does it correlate when you do the ICG and elastography with the ultrasound finding and then clinical finding?
Yes, usually yes, it's correlates.
Right, because with the ultrasound, we see the difference in skin thickness,
Yeah, exactly.
subcutaneous tissue, and mainly with the subcutaneous fascia changes in lipedema.
Yeah, you are right. And there is, in the early stages in lipedema, there is practically no fluid, no free fluid in tissue, you know.
No free fluid in lymphatic fluid or in the subcutaneous?
No free subcutaneous tissue fluid in tissue.
Yes, okay.
In lipedema case.
In lipedema, yes.
Yeah.
Interestingly, because the Italian, I think it was Maria, who demonstrated that there is a free fluid in lipedema on the top of superior to subcutaneous fascia, but it was visualized only with 3D ultrasound. And as you know, I have only 2D ultrasound, which is not easy to see this. But
Yeah, the same.
You need high technology for this study. But it's interesting that you see the changes with the ICG and the elastography.
Yes, in ICG, even in lymphoscintigraphy, in the early stages, they practically normal lymphatics flow. We can see in lipedema.
Yes.
The first alteration which we can observe, there are some dilatation of lymphatics. And if lipedema progress and the weight of patients became larger, the more changes develop.
Right.
It's very similar, I think, now, but maybe my thinking will be changing. Will change now. The changes in lipedema are the progression of lipedema is similar to that which we can observe in very obese patients.
I see.
Very similar changes.
With the lymphscintigraphy, we see in more advanced cases increased lymph nodes in the popliteal area, which in normal subjects you hardly ever see, or in lymphedema. So there are some changes in the dilatation of the lymph vessel, as you pointed out. But since I do a lot of ultrasound on different stages of lipedema, I can see in more advanced stages, you have lymphedema in distal lower extremities.
Yes, exactly.
Observe the same, right?
Yes, exactly.
Wonderful. Maybe you can show us your slides.
Oh, yeah.
And I had some pictures that I sent, and we go way back when. I think the first one was from Rome in 2014. And I have to just quickly tell everybody that Dr. Olszewski and Marzanna, and I think the one from Monokaran from
India.
India.
Monokaran.
Join us for a tour with Dr. Olszewski. Well, let me tell you, none of us could catch up with him because he was so fast, and he was the most incredible historian. He would tell us about every single building that we passed by, all the history about that. So it was the most fantastic evening we had with all of you. And I thank you for it. And it was, I believe, 2014. So please show us your slides.
Okay. So the first topic which I want to share with you is very early detection of edema in patients after mastectomy. Using ICG lymphography. So as we know, the most common complication after breast cancer therapy is lymphedema. We know that any therapy which can we use conservative or even surgical in lymphedema is the more effective in very early stages before fibrosis in the tissue develops. So the early detection is so important. So our aim was to investigate how effective may be ICG lymphography in detecting early changes in lymph drainage in upper limb patients after breast cancer therapy. This study was based on the investigation of 20 patients after breast cancer therapy without any visible upper limb edema. The patients reporting only pain, some pain, heaviness, or stiffness in some part of the arm. In all patients, we measured circumference, skin water concentration, and of course, we did ICG lymphography. And as you can see here, there was practically no changes in limb circumference before healthy and edema and affected limb. The changes in circumference, even if there were somewhere, there was minute, less than 2 centimeters. But when we measured the skin water concentration, practically at all limb levels, the skin water concentration was higher than in healthy limb. Yeah, difference between the limb circumference. There were practically no difference in limb circumference in 20 patients. And there was significant difference between skin water concentration, practically at all limb levels. So what the first more important information. And when we did ICG lymphography, we observed many changes. One of these changes was the accumulation of fluid in the hand and dilated lymphatic in forearm, like you can see here. This is one patient. Another patient, even more advanced accumulation of fluid in hand and in forearm, and some irregular lymph vessels in other part of the limb. Another patient, also accumulation of fluid and very dilated lymphatics around. One more patient, also accumulation of fluid, even in palmar area, and accumulation of fluid, irregular lymphatics above. Here we can see very dilated lymphatics in the hand and very dilated lymphatic in forearm, surrounded by some irregular lymphatics. Sorry, I can use my very irregular lymphatics around. One more example, very similar, very dilated lymphatics and accumulation of fluid. We can, in this patient, we also saw the collateral lymph flow on the chest wall. You see this. So there is very important that there was the patients without any changes, visible changes in limb, any difference in limb volume. But the changes in limb circumference was less than 2 centimeters. But the skin water concentration was higher in all limb levels in affected limbs. With the highest water concentration in the hand and in the forearm. The difference between affected and healthy limb was around 10%, but in the mean difference. But in some patients, skin water concentration was even 60% in the forearm. On ICG lymphography, we mostly observed dilatation of lymphatic vessels in the hand and in the forearm, the confluence spread of dye, which means the accumulation of fluid in tissue, dilated lymphatics in the arm, and dilated foggy image of lymphatics in the upper arm, which did not reach the axilla region. So there was the most common changes. So based on this observation, we can conclude that the ICG lymphography can detect changes in lymph drainage and fluid accumulation in patients even in the subclinical phase, which is, as I told, it's very important. This allows early initiation of conservative or surgical intervention. So this was the one of my work.
Can I ask you about this study, because I wanted to know, so you took the patient without visible edema, but did those patients had symptoms? Because you are mentioning that there is a feeling of tension and pain and so on. So were
Yes.
they all symptomatic, or some of them only?
Most of them, they were symptomatic. They complain, they appear in our clinic because of some symptoms, which was for them not unusual. And they wanted to check what happened with his arm. So most of them were symptomatic.
Okay. Well, this is, I think, the important. And have you checked this method on totally asymptomatic patients?
Some of these patients were also, most was symptomatic, but some was also without any symptoms.
Okay.
They come because they was interested what happened. They are usually very young women and very and they don't know they don't want to they know that one of the complication of this therapy is maybe lymphedema, and they want to check it very early.
Smart.
Yeah, it's yes.
Okay.
How did you check the water skin concentration?
It was used with this small device. This is a lymph scanner from Delphine. Do you know this?
Yes. So you use the Delphine for this?
Yes.
Okay. You can tell us about Delphine.
It's very easy to use. And it's very useful in daily practice. In practically, I think it may be used for for everybody who works with lymphedema patients, just to detect the sites. If there is the only one device which we have, we can use this to map the arm or lymph with the part of the lymph with most the highest fluid accumulation very easily.
So you have a kind of sensor that you apply on the arm, and
yes,
just change the position of it?
Yes, yes.
Very interesting study. And when you showed us the fluid accumulation in the chest, was it more in the axillary area or anterior chest?
This is just on the chest wall, not only in axilla, but going to the central part of the chest.
I see. And these patients were just stage 0 according to the ISL?
Yes, exactly.
Stage 0, right?
Yes.
Before any clinical visual
Yeah.
differences.
Paul, is that comprehensible for you? Because I'm afraid that sometimes we are getting into the very specialized terminology.
Oh no, I like the brain excursion, so it's great for me. I think everybody can follow that pretty easily. I mean, it's obviously very advanced research, but it's easily followed.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
In this entity that we call lipedema or lipedema, many of the patients that I am seeing in the clinic and diagnosing based on their body habitus and appearance and physical examination and complaints, symptoms, signs, etc. As you pointed out, when I look at them with ultrasound, I'm not seeing the typical ultrasonographic findings of obvious clinical edema, the so-called ant farm appearance that we see in the soft tissues that we'll see with patients with lymphedema more frequently, and certainly with phlebolymphedema very, very commonly. So what has your experience been looking, again, with traditional 2D ultrasound, B-mode ultrasound, et cetera? Do you agree that it's less common to see gross edema on ultrasound?
On the ultrasound, well, in early phases, you don't see any differences. What we see on the ultrasound, even in early phases, there may be a thinning of the skin or from overstretching, increased subcutaneous space, and disruption or dancing subcutaneous fascia. Those are typical findings. We don't see the actual fluid component within the subcutaneous tissue. In more advanced stages, we can see a minuscule subcutaneous fluid entrapment. But Dr. Marina, and right now I cannot think her last name, she presented this last year in Assisi, where in her 3D ultrasound, she clearly pointed out, and it was beautifully visualized, that on the top of the superficial fascia, there was a fluid entrapment. But again, you can see that only with 3D ultrasound so clearly. But interestingly, when we talk about the fluid entrapment in lipedema patients, when I do compression therapy, compression pump treatment, within half an hour, I can demonstrate that there is an improvement in subcutaneous value reduction up to 40%. So what are we reducing? We are not reducing the size of the adipose tissue. We are reducing the fluid component. And this was a big debate way back when, especially with the European lymphologists, where they said, the surgeons, well, there is no fluid entrapment in lipedema patients. Well, Dr. Marina showed with the 3D ultrasound, and this was published in the research of biology a few months ago, I believe, where, yes, indeed, she demonstrated, and it was clearly visualized that with 3D ultrasound, we can see the fluid entrapment.
Yeah, I think it's a very, very interesting discussion, and it's interesting for me to understand that there was that debate that you're describing early on, especially with surgeons who were trying to assert perhaps there is no edema portion of lymphedema. But I think that the argument you make about post hands-on therapy, manual lymphatic drainage, that you're seeing an obvious reduction in the subcutaneous space, it does make sense that the only thing that could reasonably account for that would be decreased fluid in that space by promoting lymphatic flow and drainage. Because otherwise, I was going to ask you historically, because you have so many years of experience in the space, has anybody used an alternative terminology? In other words, it seemed to me that somebody might be eager to call it sort of a pseudo lymphedema, where the edema portion isn't really edema, it's just some sort of genetically determined disproportionate distribution of the fatty tissue, of the adipose tissue, and things like that. I was thinking about terminology like lip dysmorphia or lip dysymmetry, or lip disproportionality. Those look like attractive names for the condition, but if it is indeed including a truly edematous portion, then of course lymphedema would be the correct nomenclature and description of the disease. It's just that on clinical exam and on ultrasonographic exam, it often is not easy to demonstrate edema with pitting edema, obviously, or fluid collection on the ultrasound. So that's why I wanted to have that discussion with you and get your feedback on all of that.
Well, thank you. You just raised a very interesting point, because even way back when, it was debatable whether it should be called lipedema, because you already put few different nomenclature for a lipedema, and perhaps in the future we would need to agree to maybe change lipedema to something else, because we know it is disproportional accumulation of the adipose tissue and starts from waist down, and in more advanced stages you can see also changes in upper extremity accumulation or enlargement. But because I see so many lipedema clinical stages, even in early phases of lipedema, on the ultrasound, I can see the changes. I am not talking only about the edema portion, but pretty much all the patients, even though it is documented that lipedema upper extremity is maybe, it used to be 30% involvement, population involvement, now it's up to 80%. I see the ultrasound changes in very early phases, where you have thinning of the skin, enlargement of subcutaneous space. But what is fascinating is that the subcutaneous fascia is interrupted. And there are so many different shapes of interruption of the subcutaneous fascia in very early phases, even though clinically you may not see enlargement, but the tissue consistency is much softer. If you compare that to a control group or a lymphedema group, the tissue consistency is completely different. It's very soft, very squishy, and so on. And with subcutaneous fascia, what I see wavy subcutaneous fascia where the adipose tissue is even penetrating through the subcutaneous fascia, or the subcutaneous fascia bifurcates. And so there are so many different changes. And I think this is such a field for a new research or a more advanced research to see what is really happening and why do we see these changes in subcutaneous fascia, even in early phases. But perhaps now with more documentation of the edema component in lipedema, we may debate, should we keep lipedema terminology as lipedema or should we keep it as something else? But also, it's not only lower body enlargement. I see a lot of patients, lipedema patients, where the legs are not very involved, but the truncal involvement is profound. So there are so many different shapes of the lipedema. But going back to the lipedema, I will try to post the article from Dr. Marina, and there is clearly shown a fluid component on the top of the subcutaneous fascia in lipedema patients.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Yeah, I would love to see that.
Fascinating research, and certainly we should follow very carefully what is demonstrated and how we can help these patients, because maybe by all this early detection, we can address their outcome, clinical outcome in these patients.
I think early detection, early diagnosis is the key to these patients, so they don't have to end up in stage 3+ and so on. As I had today, one patient who is stage 3, and she shed the tears because after few sessions, she's already getting better. And she said, nobody told me. They told me to take the water pill. And she shed the happy tears that she has less pain, and less pain because she's taking lymphatic formula. Here we go. And she's getting better. And that is the micronized, purified fractional formula, and a component of selenium and vitamin D in it too as well. Patients are getting better with conservative management, but early detection is the key, early diagnosis. And my dream is to see the kids in the first grade in the school when they do physical examination, physical PE class, where you can see already the difference in shape. And the tissue consistency is completely different. It's very soft, very squishy. And even early kids, they may have easier bruising, which is one of the components. And I've seen a few teenage girls, and they do complain of pain on sitting in the class for a long period of time. The legs are becoming heavier. And so again, early detection is the key.
Dr. Iker, I have a question then. As a sonographer, especially my early days were in the ER, and we had rule out DVTs because of edema or pain. And so many times there was no detection of blood clot anywhere. Is there something that a sonographer can look for to document as an incidental finding that may suggest that they see someone for possible lymphedema or lipedema?
Well, number one is a typical shape change where there is complete asymmetry of upper body from lower body. And again, when I see adult patient, I ask them to bring their daughters. And I do the ultrasound, not only the physical findings, but also the ultrasound to correlate. But the youngsters, I mean, when they are very active, they are not going to tell you much other than maybe easy bruising and heaviness in the legs. And increased size from waist down. And when does it start? Typically, it starts with the onset of first menses, where all of a sudden the girls are ballooning up. And I had one 11-year-old, within 1 year after her first period, she ballooned 80 pounds plus.
Wow.
And this is not normal. And it's not an endocrine problem. This is lipedema. And there is a fluid retention, by all means. And when I compared the mother to the daughter, it was the same picture. And again, early detection is the key. And the tissue consistency, when you feel them, when you see that, when you put your hand on the tissue consistency, it's so very soft. It's so, I would say, welcoming, but it's a little squishy, as opposed to a normal subject or lymphedema. Lymphedema tissue is much harder than lipedema. But lipedema tissue, it's not only in the legs. You can feel the softness of the tissue consistency. Why? Because it's connective tissue disorder and it's everywhere. And when I do the physical exam on the face, you can clearly see that. In one of my lectures, maybe I should do that one day, where I'll show you all the different signs of the lipedema on the face and throughout the total body evaluation.
Emily, we should do this.
Let's do that. Yeah.
Yeah.
Let's do that. And I'll show you on the kids,
Yeah.
what do we look for? What do we see? And you have also frequent hypermobility of the joints. And from time to time, when I watch the gymnastics, and you see these beautiful girls and with the knees bent backwards. And I look at this and I said, oh my God, potential lipedema. And there, I mean, I should not do it, but yes, indeed, it is there. And I had one patient, her beautiful daughter was acrobatic gymnast. And then she stopped because she went to college, and all of a sudden she gained 80 pounds in 1 year. And when you look at it, mama has lipedema stage 2+. And the young lady, because she was exercising vigorously, but she had hypermobility of joints too. And then she stopped and she gained so much weight, and they don't change the diet much. That's the interesting point.
Dr. Iker? I think Emily, I think Jackie's question was an excellent one, and your response is fantastic. We're going to sign off in only 2 minutes here. I know Dr. Gloviczki has another obligation, but in terms of the tissue consistency and the connective tissue problems, maybe you could just say a few sentences about any connection to Ehlers-Danlos syndrome and also the tissue consistency on physical examination that you might see and appreciate in Derkham's disease.
Oh, excellent question, Dr. Chuback. With Ehlers-Danlos, I do believe we need more research on the genetic malformation of the lipedema patients, where I think there is some cross bridging between Ehlers-Danlos and lipedema. Ehlers-Danlos doesn't have the disfiguration of the lower body enlargement in symmetrical distribution as we see in lipedema, but Ehlers-Danlos has the hypermobility of the connective tissue, and you can stretch the skin as far as you can and so on. So I think that there is some genetic disproportion somewhere where they may share the same malformation of the DNA, but not to the full extent as we see in lipedema patients. The hypermobility may be one component. And in terms of Derkham's disease, from what I've seen so far, pretty much all Derkham's disease start as lipedema patients. and there is some inviting factor, whether it's trauma or something else, where there is accumulation of adiposity throughout the subcutaneous tissue. And I will present this, and I don't want to mention too much, but we see the almost like snowball appearance on the ultrasound. And sometimes you can see it on physical examination when you see a little bump under the skin, and the patient tell you that's exquisitely painful, which lipedema patients don't have the intensity of the pain and don't have the localized accumulation of the adipose tissue, painful nodules. And that is typical for Dercum's disease. And I've seen Dercum's disease in superficial subcutaneous tissue, deep subcutaneous tissue. I've seen on the ultrasound juxta-articular Dercum's nodules, and I will present now Dercum's nodules in the muscle tissue, which that was never described yet. And I have several patients that unfortunately they had sedentary position and couldn't sit for a few hours, and nobody could find the reason why. Well, with the ultrasound findings, we clearly see that there is Dercum's nodule within the muscle tissue. There is so much research to be done on Dercum's disease, but pretty much, and I want to again work on that segment to find out why do we develop Dercum's nodules? And it seems like there is some triggering factor, whether it is physical or emotional or something else that we need to research out.
Thank you very much. Paul, I think we'll wrap it up here. I think it was a fantastic program. Unfortunately, we lost our esteemed guest halfway through. Perhaps we'll be able to invite her back again another day to share more of her research and her knowledge with us.
Yep, let's do that for sure. She had a lot of great information that we heard, and obviously more to go. But let's thank our panel. You've been watching and listening to LymphCast, episode 27. From California, Dr. Emily Iker. Thank you, Dr. Iker, for everything.
Thank you. Wonderful team. I wish we could hear more Dr. Marzanna, but maybe in the future.
All right. If you don't mind, Dr. Iker, can you give her a thank you as well? She's not here to hear it, but she will when we put it out there.
Thank you. I will email her.
All right. Very good. From Arizona, Dr. Monica Gloviczki. Thank you, Dr. Gloviczki, for everything.
Thank you very much. Thank you, team. And thank you to our wonderful guest. And we have to invite her again, because we like in the middle of this story. So we want to know the follow-up.
All right, very good. And back in New York, although she never actually left, RVT, Jacqueline Sasek. Thank you, Jacqueline, for everything.
Thank you, Paul. It was a great show. Thank you.
All right, thank you. And the founder, owner of Vita Support MD, also the founder, owner of this show, the LymphCast show. Vita Support MD makes lymphatic formula 1000 and vein formula 1000. Physician surgeon from New Jersey, Dr. John A. Chuback. Thank you, Dr. Chuback, for everything.
Thank you, Paul, and thank you to everyone on the program who helps us to raise awareness and educate our colleagues, and also educate lay people out here who they themselves may be suffering from these problems, who are often misdiagnosed, undiagnosed, and also many people who have loved ones who are suffering with these problems and are searching for answers. So I think our program remains important, and we continue to learn together as we go and as we educate. And I want to thank everybody again for being here this evening. I look forward to our next program.
All right. Thank you very much. We want to remind everybody, go ahead and listen to us on Apple Podcasts and Spotify. We're all over the place in the podcast world. And also fire up YouTube and look for this show as well. Again, this has been LymphCast, episode 27. Have a great night. We'll see you next time.